Loeys-Dietz syndrome was first reported in 2005. This autosomal dominant genetic syndrome demonstrates many clinical characteristics similar to Marfan syndrome, including aortic aneurysm or aortic dissection. Additional classic physical characteristics include orbital hypertelorism, cleft palate, and bifid uvula. Mutations in the genes encoding transforming growth factor beta receptors 1 and 2 are associated with this syndrome. Loeys-Dietz syndrome classifications include type 1 and type 2. Type 1 Loeys-Dietz syndrome tends to demonstrate more severe cardiovascular anomaly compared with type 2 Loeys-Dietz syndrome. The figure shows aortic diameter in patients reported in the literature with Loeys-Dietz syndrome. Significant dilatation of the aorta was seen even in small children. The patient in this report, shown with a yellow dot, is one of the youngest reported with Loeys-Dietz syndrome who had successful surgical treatment with valve-sparing aortic root replacement. The patient's body weight was 12.2 kg. The chest X-ray showed a dilated heart and aorta. Echocardiogram confirmed moderate aortic regurgitation as well as mild to moderate left ventricular dilatation with systolic and diastolic dysfunction. The annulus of the aortic valve was dilated to 21.4 mm in diameter. Computed tomography showed dilatation of the aortic root with a marginal dilatation confined to the proximal ascending aorta. Surgery was performed through a median sternotomy. The pericardium is opened, revealing the enlarged aorta. The aortic dilatation is particularly prominent at the level of the root and proximal ascending aorta, which is typical for Loeys-Dietz syndrome. Total cardiopulmonary bypass was established between the distal ascending aorta and both vena cavae. Myocardial protection was achieved using moderate systemic hypothermia and antegrade cold blood cardiopressure, followed by retrograde cardiopressure, repeated every 20 minutes. The ascending aorta was transected at the level of the sinotubular junction. The aortic valve was carefully inspected for proceeding valve-sparing aortic root replacement. An incision was made above the left coronary cusp, and the left main coronary artery was carefully dissected. In this patient, you will see that the left main coronary artery needed to be dissected off the posterior aortic wall to allow the left coronary ostium to be harvested. An incision was made above the right coronary cusp, and the right coronary artery was carefully dissected. Approximately 2 to 3 millimeters of tissue is left above the valve annulus. This is helpful when later suturing the valve to the ductal conduit. An incision was made above the non-coronary cusp, again leaving some sinus tissue for the later suturing of the valve to the ductal conduit. The aortic annulus was sized with 19 and 21 mm dilators. A 20 mm gel-weave valsalva prosthesis was chosen for reconstruction. The proximal sleeve was trimmed to be only 2 rings long. A traction suture was placed at the top of each of the 3 commissures. For reconstruction of the aortic annulus, a project-reinforced Prolin mattress suture was placed below each cusp. The location of each mattress suture is shown in red on the inside. After placing 3 mattress sutures below each cusp, 3 more mattress sutures were placed below each commissure at the same depth below the valve as the previous 3 sutures. These 6 projected sutures shown in red will serve to put the dacron over the valve and fix it at the appropriate level to allow valve suspension inside the graft. The 3 traction sutures on each commissure post are now passed through the graft, and the graft is placed over the aortic annulus and secured in the position by tying the projected sutures. The traction sutures at each commissure post were passed through the graft at the sinotubular markings on the gel-weave dacron graft, and were temporarily secured to the graft to confirm final positioning of the aortic valve. 3 tourniquets were used to check the valve competence. This technique allows the surgeons to ensure valve competence prior to tying the sutures. A competent valve should hold setting. 5 Prolin running sutures were used for anastomosis of the aortic valve to the graft. The suture line begins at the base of each valve sinus and is run to the top of each commissural post, as shown in red on the inside. New coronary artery orifices were created in the sinus portion of the graft. The left coronary artery was anastomosed to the graft. The right coronary artery was anastomosed to the graft. Cryoglue was used on the anastomosis sites before distal anastomosis. Dilated ascending aorta was excised and distal anastomosis was performed to the more normal distal ascending aorta. The aortic cross clamp was taken off and the cardiopulmonary bypass was safely discontinued. The post-operative clinical course was uneventful. The patient was discharged from the hospital 6 days after surgery. Post-operative transaortic echocardiogram showed mild aortic regurgitation from the central area.